Hi, good afternoon or good morning, depending on where you are, or good evening, depending on where you are in the world. My name is Greg Heffer. I'm Vice President of Academic Affairs for Residence Medical, and we have two wonderful guests here for our webinar today. And we're going to talk a little bit about, the status of applications as we are quickly approaching Match Week, March 16th and how both IMGs and US grads will be dealing with Match Week and try and continue on if they don't match in or prepare themselves as they do match in. So I'm here with Dr. Raj Patel. He's a very experienced program director who for almost over 15 years, I think, ran the anesthesiology program at USC CAC magnificently. And he has a lot of experience for you to listen to today. And I'm also here with Dr. Shravani. She also is part of our alum group of matched students here that we help at Residence Medical. And she has pre-matched in a program as any students who were fortunate to get into a pre-match or an out-of-match program. Those programs will interview during the season, but they will then offer contracts and choose through December, and January, sometimes even as late as February. But those, trainees then have to, alert NRMP that they have basically a job and they are now out of the match and they are able to withdraw. So I want to welcome both Dr. Shravani and Dr. Patel to our discussions. And Dr. Patel, why don't you talk a little bit about what we're expecting and what's going to happen here now in the next few weeks once we get to Match Week?
So, hello, good morning, everybody in US and other countries may be different timing. Uh, so the match week will be your March 16 Monday, and usually coming up to that date, the apprehension is high. You've done your best during your application process, your interview process, and now everything is, waiting on the match day. There may have been the communication with your program directors uh, in January, February regarding your interest in the program. They may have replied you. And putting all that together, you may have a feel whether it looks positive or looks neutral. And in that case, we're waiting for the date, Monday the 16th. It's at 10 a.m. You will know exactly if you matched. And if you matched, all worries are off and you just wait till you find out on a Thursday where you matched. And usually, I think it's Friday morning, 9 a.m., that you know exactly where you matched.
Right.
So, I mean, we can discuss further as we go along, but this is usually the process that we are looking for. I think today's discussion is all about the soap matching and how can we help in discussion today.
Yeah.
Keep your process simple and easy.
Right. Absolutely. And in fact, the match for March 16th for many is not just a results, it's a decision point for many. If you are fortunate to match in, your life is now going to be directed to wherever that is in the United States at that particular residency program. If you do not match in, you're going to have to create some new strategies, look at the next year. What are your engagements? What are your plans? And in fact, it's good to have that prepared because those who are not prepared to deal with not being matched are often at a disadvantage because this is critical. Um, I want to talk to Dr. Shivani a little bit. By the way, it's Dr. Shivani Kumuru, and welcome. I know you, I think, went through the process of not matching, and share with me a little bit in terms of how you were able to respond to that, and what are some of the challenges of that?
Yeah. Hello, everyone who joined us today. First of all, I want to wish everyone a good luck for match day. I hope everyone gets their result in a very positive way. But for me, when I was applying, things didn't go my way, not once, but twice. It was devastating, obviously. It took me a while to rebound. It took me some like over a few months, I was not able to digest the fact that I didn't match. But then I realized it sometimes depends on so many more factors than scores, so much more than the number of interviews. You just need one right opportunity, and you are just in, like just like that. For me personally, when I didn't match for a couple of times, I reached out to Residence Medical. I had my personal statement tailored in a way that was very beautiful. It was the same content, but the way it was put together made a lot of difference. And then I did extensive interview preparation with Residence Medical, and that kind of boosted my chances more than I knew. Because from my first two cycles to the cycle that I matched, my scores didn't change. I'm the same person, but it's just that I had a beautiful way to put my story together. I found meaningful clinical experiences. I was fortunate enough to do some research with Residence Medical. So I think that's what helped me with where I am today.
Thank you so much for that sharing. One of the things that we do also is we do use actual program directors for our interview prep, and I think it's some of the best in the country, and it's really a challenge. We can talk a little bit about that too, actually. Dr. Patel, you have a lot of experience of interviewing residents over the years, and you know the experience of them in person and also virtual. And as you see what's happened, we're kind of like we've moved since COVID to almost all virtual. However, there are some programs that are doing in person. But what's your take on that, just in interviews in general? Because the results of a person's matching often are directly connected to that interview or interviews that they've had and how they were presenting themselves. Thoughts, Dr. Patel?
Yeah, so the interview process did change during COVID, and at least I can speak from the anesthesiology perspective, where we are still virtual. And I think the American Board of Anesthesiology decided that they will advise, and American Society also advised that we continue with the virtual admissions. Now, is it advantageous to be virtual, or was it a lot more impressive when it was direct interview face to face? In my opinion, the residents had a better chance to review the institution. They had a better chance in directly communicate with the group of residents the night before that we used to arrange for the interviewees. And the whole day that they will tag along with us in different parts of the hospital. Our goal as a program was to expose them to the maximum number of faculty and maximum number of residents as much as we can. One of the things I used to always say that residents never get paid enough to lie about the program. So, those are the people who are going to tell you the real truth.
Right.
And that was one of the goal of ours, that the department had, um, you know, uh, had a funds for the residents to take them out the night before for dinner. And I think that was the best part, which impressed our applicants to our program. Of course, we being in Los Angeles always has a hidden advantage. All programs in California has advantage. I mean, imagine tons of students leave California for med school somewhere else, and guess what? Their parents are telling them to come back home, and so those are the advantages part of the California. But overall, if you look at what is happening today with virtual, uh, the exposure is not that great. I mean, they try to have you talk with few faculty, few residents, but not like the old days.
Yeah. Yeah.
Um, and that also makes a little difficult for us to judge how to place people on different levels. I used to, always take feedback from the residency coordinator, the secretaries who take them around the hospital for for the tour. The residents will meet. I think we were looking at more of a professionalism picture through that.
Right.
We were able to see who is more engaged during the day, or they are looking into the phone and not really interested. So those little things have now disappeared.
Right. In fact, I remember you once saying professionalism is one of the toughest things to judge on a,
Because
correct?
look at it this way: who does a program director want? Program director wants a resident who can communicate very well with everyone in the hospital, because that's the key part of communication, who has the best professionalism. When it comes to professionalism, work ethics, I mean, these are the things you'll never find out on an interview, because, I mean, those are the tough things. And that's what they want. They want a resident for the next 4 years or 3 years, whichever the duration is. They don't want to have a complaint about the resident that the program director has to call resident to the principal's office. I mean, the other things are the key piece the program directors like, and actually in an interview you should actually focus on it. And is you're going to go an extra mile than any resident to improve that program to the next level. That is the job of the program director along with all residents. But they love that sentence, because here is a resident who's going to help me for next 4 years take this program to the next level. So they want leaders. They just don't want regular workers, basically.
Yeah. Trainees that are going to actually embrace this training school and really help it shine. So, and I think that's true. I know, Shivani, you had several interviews, and you probably can share about your experiences. Right now, there are students that maybe they've applied in the match, they got no interviews at all. So they're looking at maybe SOAP. It's been a tough year. The visas, for example, have been kind of discontinued in a number of programs. A lot of U.S. medical school residency programs are not hosting the J's because of the delays and because of the current climate here with the immigration offices. So that's created challenges, especially for IMGs. But let's look at just the interview, because one of the things that Residence Medical is good at is helping create interviews for candidates who have been in Eros. They don't have anybody there to advocate for them. And sometimes they just need to get a chance to get in front of a program director and to be able to show them their gifts that just are not always there on a piece of paper. But share with us a little bit about your experiences with interviews, Shravani.
Yeah, so I've had like close to 10 interviews this season. Most of the interviews I've known that the program directors, they're not looking for like if you're a if you're a person with insanely high scores but you're camera shy, or if you're just hiding away from all the residents who are there virtually talking to us, or if you don't maintain a good eye contact, or if your communication is not on point, it just doesn't matter, is what I felt. Most of my interviews were so friendly, like they were looking for someone they can work with or they can have in their program for the next 3 years. Um, it was more about, can this person get along with the rest of the program? Can this person do good communication with the patients? So that was my interview experience. And I would say, as much as it is important to have like we are IMGs and we do have a lot of apprehension that, hey, I want my rank order list to be super long. But to me, I feel like it doesn't matter if you have 10 interviews, you need just one good interview to match. And yeah, as IMGs, we do need someone to advocate for us, to open that door for us. And that's what Residence Medical has done for me.
Yeah, we're very aware also in the interview process in Eros the certain filters that different programs have. I think, Dr. Patel, you probably had a certain USMLE cutoff. Other programs may have a cutoff that may be lower on their USMLE scores for step two, which is a lot of focus. Others will have filters for a visa. You know, you want to make sure if you do need a J visa, if you're an international IMG, that you're not applying to programs that are not hosting visas. And by the way, just as a clarification, sometimes they'll say we do not do visas, but it's actually ECFMG is the official grantor of the J. What the programs do is there is a form that they fill out that the DIO sends in, and it says that they would agree to be a hosting site. But as we saw this year, because of delays in visas, some programs are pulling out of that hosting opportunity. So it makes it more difficult for an IMG to navigate where they're applying to. And these are some of the other filters they're dealing with. Years of graduation is another one. If you're more than 2 years out of medical school, most of the US medical school residencies are probably going to filter that as well, whereas the community-based might not. But overall, let's say somebody has no interviews. They applied in the match. They just didn't get any interviews right now. They're looking at SOAP. What should they, I mean, let's talk about SOAP. You know SOAP pretty well. What really is going on? Because we've talked about this, most of these SOAP positions are going to go to the US grads, up to 85%. But tell us a little bit about that.
Okay, so usually if you look at most will get ready for a SOAP even before the March 16, just to mentally be ready for that day. At least you know what to do. If you look at the review process and the interview process, which is Monday and Tuesday, and it opens up with the applications on ERAS again, and you may get slots for interviews at that time. And then later on, Wednesday and Thursday are the 2 days where NRMP will conduct 4 2-hour offer rounds. And, I mean, there are 2 on Wednesday and 2 on Thursday. 9 a.m. and 12 p.m. Eastern Time. And that's where you get your offers. If you get the offers, you're taken off the list, and the list gets smaller and smaller as you go towards the end of Thursday. And whatever is left at the end is open for students to call the hospital and the program director if they want to directly talk to them. But until then, they cannot call the program. The program must communicate with the student. You can only do your ERAS application, and that's about it. Again, getting ready for the interview is extremely important. If you look at medical schools, they have a little advantage if you look at from the perspective. Most medical schools, the dean knows Sunday night which students in which programs did not match at their institution. So the phone call goes out at 9 p.m., 10 p.m. They don't care at what time. They're going to talk to those students personally. And they actually tell them to be open for communication on that Sunday night. And everybody's basically waiting. So if you don't get a phone call from Dean's office, great. But that's all about the US medical schools. The students arrive in US medical schools 7 a.m. Monday morning, and all the rooms are set up for them for the interviews. So that's the advantage from the institution perspective. Here, on a personal basis, you have to get set up for your interviews and your applications. And that's where if you need help, help is available. Either you know people who have knowledge about it, or institutions like Residency Medical who can help you with this process.
I was going to say, yeah, we do help with because we do put and help students into SOAP every year, and we have affiliations with different residency programs, different specialties. There are some specialties, for example, in general surgeons, something I was going to ask of you, Raj, and Shivani, we can talk about this. But for example, many general surgery programs put their prelims, PGY1s, into SOAP. So there is a lot of matriculation into prelims in general surgery. IMGs will sometimes try and see if they can just get into a training program. And so my question might be, and I think it might be for some of our also viewers, is that a good strategy just as a backup? Let's say you applied in internal medicine or even primary care, family, didn't get any interviews. And you're thinking, well, maybe some training would be better than no training. Would that be a strategy to maybe apply for, let's say, a PGY1 in general surgery?
Yes, so I can speak about it a little bit. For many, many years, anesthesiology was a 3-year residency with a 1-year internship somewhere else. Over time, people have converted it to 4-year residency, and they will give them the internship at the same institution. So I would say right now, 60% of all the programs are 4-year in anesthesia, and 40% are still 3-year anesthesia with internship. And that's where, when we give them advice about where to apply for their internship, we had a number. I mean, I can speak for the US graduate more right now, because we had a number of 20. It's all or none. So you can't apply to 5 prelims and say, okay, I'm going to get my internship. No, you got to apply for 20 prelim programs, of which we would say minimum 10 of surgery. And the reason we added that piece is we knew that a lot of programs have surgery positions open on prelims.
Right.
And so that way, I know our medical students don't like to do surgical internship because it's hard work and it's different. Um, it may not be the best match for anesthesia residency because anesthesia is all about medicine. So the base is the medicine. And so they would love to do family practice, internal medicine, that type of prelims, open prelims, or a transitional, rather than going for surgery. But our goal was very simple. You cannot apply for a 3-year residency and not match in a 1-year residency. So
Right.
the goal was to focus on surgery. If you don't get any other, at least you got surgery, and then you at least have a life going forward.
Yeah. But you're
So,
saying that a lot of anesthesiologists, they prefer a transitional year or a internal medicine prelim or even primary care family as a first year before they go into categorical 2 anesthesiology.
yes, because that helps the anesthesia base the best. Because what
Yes.
happens with surgical residency, not to, at this moment, any residency is great. But I'm saying surgery, if I look at a community surgery prelim, it is actually better than a big institutional prelim surgery. Because what happens in community surgery is that you do everything from point A to point Z. And you basically see the patient in the ER, in the clinic, you discuss with the attending calls you to get some workup done, and then you discuss again. The attending walks in, decides we need to do surgery. You go to surgery with the attending, finish the case, take care of the post-op. You are involved at every stage of that patient. And
I
it's a
got you.
great training. When
Yeah.
you attend a surgical prelim, at a big institution like UCLA, USC, New York, wherever, what happens is they have a categorical surgery and they have the prelim surgery. So basically, it's like a second class citizen, in my opinion, because we've seen that at USC. Basically, they are just scut work on the floors and dressings and H&P, admission, discharge. And the other residents will tell them, oh, you don't need to go to the OR. What do you need there for? Only for 1 year. So it's not a good residency. But again, whatever you get to finish a 1 year of internship is better than not getting matched anywhere.
Right. Yeah.
So, put it into that. Any experience in US is going to take you to the next step very easily.
Yeah. Shivani, I have a question to ask you. Now, you matched into internal medicine, and it's a little more competitive than family medicine, primary care. Although there's massive, massive needs across the United States for family medicine doctors all over the place, and just the needs in every state, literally. But let's say somebody, and Broderick, and we'll ask you also, somebody has applied in internal medicine. They didn't get any interviews. Should they then shift, Shivani, do you think, to try primary care? Because we at Residence Medical, we will help students who didn't get interviews in one specialty. We might have opportunities in family medicine for them to get in if they're finding it very, very difficult. What is your take on that?
So personally, when I was applying, I defined my goals. Residency is one part, and what I want to do after residency was also there for me. I personally wanted to do a fellowship, so I was dead set on doing internal medicine because I know what my future goals are. But if you want to do internal medicine and maybe then stick to primary care, family medicine might not be the worst choice in that case. And just as Dr. Patel was saying, at this point, I would say it's better to match somewhere than not to match anywhere. And especially if someone is an international grad like me, they don't want to be 3 years or 4 years out of medical school and just keep waiting and waste another year or sit in the hopes that something is gonna magically change. Either seek out help and try to fix your application in a way that it's suitable for most of the internal medicine programs. If it's research or if it's rotations or if it's interview prep, try to get that. Or it's not like it's not 100% bad to have a backup just in case. My case personally, I did not want to have a backup because I knew my goals. So, my advice to whoever is applying this cycle or looking at SOAP, I would say define your goals. And if you feel like it's important for me to match, then go ahead, have a backup. But if someone feels like, no, this is where I want to be, tailor your application and get help on that.
Right. A lot of the 7,500 7,800 a year of the IMGs that match, about 3,000, excuse me, matching internal medicine, and about another 1,500 matching to primary care, and then I got about 500 or 600 in peds, and then the rest are prelims and general surgery. Some very high scores and very tough, like general surgery categorical. But overall, I would say many people choose, right, internal medicine because they want to do fellowships. They want to do cardiology or GI or maybe endocrine or hemonc. And we help some of our students that move into residency later with fellowship as well. And it's gotten extremely competitive, as you well know. But that would be a decision point for some students. And we talk to students that come to us who have no interviews, and we'll look and see, well, we may have some opportunities in primary care. Do you want to consider that to do that? Family medicine does have their own fellowships, as you well know, sports medicine and addiction medicine, et cetera. But it's, if you're dead set on cardiology or GI, as many IMGs are, it's hard to talk them out of it. But again, realistically, that is part of these decisions that one has to make if they get no interviews, or if they even did and they didn't match. Because as you well know, to be year after year, you get a few interviews, you're just not getting ranked in for some reason, to do that. Raj, I know when you do interviews, and I've talked to a lot of program directors and we affiliate with them, if the person's scores are not real high, and if there's a way that they are able to get an interview with a program, maybe they're doing research, maybe as we often do, we integrate them in a residency and they spend time with them doing research. Sometimes even the committee will, when they interview, they will not allow many members of the committee to see the scores. They want to, interview the person or judge them based on what they see and, on their CV. Well, what would be, I guess the question, because we get a lot of people that are saying, okay, God, I got no interviews. What do I do? So I'm going to try and SOAP, where I need a visa. So I've got to, it's going to be a program. If they're in SOAP, they've got to be able to host a visa. If they do get an interview, we talked about how they should prepare, and we have some wonderful preparation for them. But what would they do if in the match, do you think, or in the SOAP, I should say, and post SOAP?
So if you the best way to look at this is which specialty you're applying to. So goal should be, yes, what you want to do in your life, but the backup system should be always there. Because every year you don't use a backup, initially you have delayed by 1 year if you don't match. And that's why I always believe, and I mean, I don't want to give my example, but those days were different. Anesthesiology was very competitive. I came here in 86, and you won't even believe what I did. It's surprising. But when I came here, remember the word was you have to survive on your own and fight your game until you get your residency. You got to eat. So the goal was a job over what specialty I get, because I can always change the specialty later. It's not a problem. So I applied to close to 900 programs. And we didn't have to pay for all that. Now you guys have to pay about 30 or 40 programs. But the only thing we had to pay was a 50-cent stamp on an envelope, which goes by mail with your CV and your general application with all the details. And it just goes to the program. If program likes it, they write you back saying, okay, we have an interview on this date and please show up. I had applied to 8 different specialties. But remember, the goal was not at that time that I want to do anesthesia or medicine or surgery. The goal was I want a job first, and then I'll figure out from there. So the point I bring it up is you need to be aggressive when it comes to application. More number of places, more specialties. Like, everybody knows that pediatric is much easier to get in United States than other places. Well, I don't like kids. I don't like pediatrics. Fine, put it as a backup, but at least apply. The internship of pediatrics is excellent. And I've had so many anesthesiologists taken into my program who were already an internist and pediatricians, but then they wanted to do anesthesia. So, okay, fine, you won't finish in 3 years, you'll finish in 6 years, but you're going to be a double boarded, the best doctor that you can ever imagine.
Exactly.
So that brings up to the point of how aggressive you need to be with these things. Time is extremely important. When it comes to interviews, let me tell you how the programs look at applications now. When the applications, let's say at USC in anesthesia, we used to get 250 applications and we had 18 positions. Simple program directors will go through all that and then also ask 3-4 faculties to review them and create some sort of a scoring system. We had a scoring system. Now you get 900 to 1,000 application in anesthesia at USC. Guess who is reviewing it? Not program director. It's the program coordinator goes through it. They have been given certain criteria that we need everybody above this score, and let's see how many we can get for interview. The typical number for selecting interview is 10 times the number of positions you have. So if we have 18 positions, we need 180 to interview. That is in the specialties which are very competitive. The specialties which are not competitive, let's say pediatrics, they will need 7 times the number of positions. If you look at neurosurgery and ENT and orthopedics, they'll need 35 times the number of positions they have. Because the point here is it changes who calls who at what stage. So remaining a little bit aggressive, and that's why I say you should always apply to prelims, even if you applied to internal medicine, you applied here, even on a regular basis, you can apply to prelims. You don't need to wait for the SOAP to apply for prelims.
Yeah.
If they accept your application and they like you and they're going to work on your J1 visa, or maybe you already have a green card, it's easy to get into that. So think like what other avenues you need to apply as a backup, because backup is a key in saving time.
Absolutely. And we see that having that plan is very, very important. Shivani, when you were applying, did you focus only on internal medicine when you were applying, or did you also include some family medicine as well? I think you had mentioned that. I know you wanted to do fellowship in internal medicine.
Yeah, so when I was looking at programs, my main focus was on internal medicine, but I have to admit I did apply to like close to 10 family medicine programs because I was already 3 years out of school. I don't know if I would have reached a point where I have to do a rank order list. Maybe family medicine would have been at the bottom. But when I was applying, I did apply to family medicine because I would rather spend an year in a family medicine program. And then if I don't like it, I would have applied again to internal medicine. But I would get some training over no training. I would be a resident than someone who's trying to be a resident, especially me being an IMG who needs a visa and who's also 3 years out of med school. So I did apply to
Absolutely.
a few family medicine programs.
And were the interviews that you got, were they mixed? Did you get some in internal med and some in family?
Yeah, so most of my interviews were internal medicine. I did get a couple of invitations from family medicine programs, but those interviews, they kind of reinforced why I wanted to do internal medicine. Um, I felt I would be a better fit for an internal medicine program. But as I was saying again, if it comes down to a point of me being a resident, to me not being a resident for 1 year, I would pick the first option. I would want to be a resident somewhere and get some training over no training for a year and trying to apply again. So from my experience, I think once you're in the system, there's a lot more you can do. There's a lot more people in your network. You can, hey, you know what? I did apply to family medicine. This is what's been going on for a year. But I feel like internal medicine is a better fit for me. If I was in a family medicine program, I would see if the program has also internal medicine. I would go to the PD, talk to them. I think there's a lot more that you can do when you're within the system than uh, outside the system and try to make your way into it.
Absolutely. One of the things that we help with candidates when they come to us who haven't matched or are looking at, we will evaluate even their clinical rotations and what they have. If you're trying to go into internal medicine, you really want to have inpatient, in a residency, in hospital for internal medicine. That's what the program directors like. If you have graduated from medical school, there's only about 8 states in the United States where that is legal to do. California is not one of them. In fact, our medical board is very strict and will fine doctors to $25,000 if their hands, if they're touching patients because, we are not a hands-on state. But Maryland and Florida and Ohio and Illinois, where Dr. Patel was with Rush doing rotation, they are legal. And this is something that we look at because in the application process, if they're looking at your clinical experience, you really want to make sure you have that. And that's why when we set up rotations for students that come to us, we're very particular about that and what the specialty is, especially internal medicine, because a lot of IMGs, that's what they're applying to as well. And I think that some of your clinical experiences too were helpful as well. Correct, Shivani?
Yes. So for me, I think what changed the game was when I signed up with Residence Medical to get my profile reviewed, to get my ERA CV and my personal statement tailored in the best way possible. I did give my counselor my list of programs, and I was very fortunate to be put in a meaningful rotation with the program that I matched. So that I think gave the program a better chance to understand who I was, to know a little bit more about me, and it gave me the same chance. So that was what helped me at the end. So, if you are getting a chance to do an inpatient rotation or an in-person rotation at a program who has residency, I would say take that opportunity, make the best out of it, and know like who you are supposed to be reaching out. Keep all the residents in your network, and you never know what's gonna pan out for you. So tap every door that's possible is was my motto for this season, and I'm so glad it worked out beautifully for me.
Yeah, thank you for that sharing. And Dr. Patel, from what you had said too, being more aggressive and engaging. But you said something very interesting too, and that was that, a doctor, let's say if they went into pediatrics, even though they want anesthesiology, they do that, and then they go into anesthesiology. They get double bored. What they are creating in their career is a really good physician. And I think that is a good thing to put in your mind, as a physician. If you have not matched, what you're trying to do is you want to get into the training because you want to be the best doctor you can be. And when you're in that residency, you want to help bring that residency up to another level, as Dr. Patel said. In other words, the focus is always to be the best professional, competent physician you can be, so that even the residency will come if you can step back from and say, hey, look, I want to get into training, and I will, and I want to be the best resident I can be if I get in, because I want to be a really good doctor. And I think there's something really of value from that, whether it's your professionalism, your clinicals and everything like that, and the decisions you're making. But I think the program directors respond to that, that attitude. Wouldn't you agree, Dr. Patel?
Yes, definitely. Someone who's already been into the hospital system for 2 or 3 years is a plus. Someone who has been working with residents and with faculties and with hospital divisions and different departments is an experience. And all these things add up to what you want to really do. Of course, it is, let's say you get matched into even a prelim in a major institution. That 1 year is your opportunity to impress the hell out of every chief resident in that cafeteria. Because that's your ladder to the next level. And once the chiefs are impressed and other residents they speak up. And once the residents speak up, the program directors don't object. They love it. That's fine. You guys want a partner in your residency? You got it.
Yeah. Yeah. Shivani, your take on that?
Reach out to me, I would I would say, like, hey, if you know a resident, just don't hesitate to call them. Call them if it just don't feel that, hey, maybe I'm bothering this person. Maybe I just don't have to intrude so much. You want a residency, so do whatever you want to get residency. I keep hearing this all the time. If you tap on a door, the worst thing that's gonna happen is they're gonna say no. But if you didn't even tap on that door, you don't even know what's behind that door. So talk to as many people as possible. It's nice to have a resident who's vouching for you, because from my interview experience, and I do agree with Dr. Patel, if a resident speaks up for you, if they say that you're going to be a good addition to the program, I don't see a problem with why the program director or the leadership wouldn't rank such a person. So I 100% agree, and I advocate for all my fellows who are applying and juniors who are trying to apply next year. Have residents in your connections.
Thank you so much for that. We've got a few minutes left. I was going to see if we've got a few questions that have been sent in, that I see up here. We've covered a lot of even what the questions, for example, one attendee said, what should I do if I have no interviews? How do I approach SOAP? And we've talked about that is you're going to just, you're going to apply and see where you can get some opportunities and be open to those different choices. Any additional points you want to make about that, Dr. Patel?
I think it's a collective effort. You will not miss any opportunity to get a consult from anyone you know at that moment. Try to explore more. And again, I stress on the timing. You guys are absolutely right in your earlier discussion that the more years you are away from your medical school, the less impression you can create on your interview. Because it's a gap, it's a gap with no presence in the hospital. Even if you had to volunteer if you get a place to volunteer and say, they, you know, there were days when hospitals were not bothered about insurance coverage. Right now, they have this big deal that you go to any hospital and say, I will volunteer, I'll come free, and this department is ready to do the research for me. Unless they apply you as a research candidate, you're not covered by the insurance. So if you say I'm an externship, an observer, well, that's a liability to the hospital for insurance, you know. So so there are, you got to find ways to get into the system. The best way is to find who's the best researcher of that institution in the area you live, so you don't have to really change to another city, and approach them. Most of the people don't mind, if they have a funded research position, they'll give it to you. Or maybe take the unfunded one initially until someone else who was funded is now gone to the next step and you get that funded position. That piece in a big institution really is a good ladder to move on to getting a residency in that hospital. Now, which specialty, it's up to you, how you communicate in your free time with other residents, get their advice, that's why I say that 1 year of your experience in research is going to open up a lot of doors in the cafeteria. Don't underestimate cafeteria. That's the place everybody comes. And that's where you get your connections and networking done.
That's a good piece of advice. I've heard some program directors will move a research candidate up to the top 5% of the applicant if it's really good research. So that is often in competitive specialties, it's really needed too. I will say this, some of the candidates that we help too, their scores are not necessarily very good. They might have some attempts. One of the things that we do, besides giving them some research opportunities within programs to get them inside and out of EROS, is we will have them sometimes take mock in training exams for that particular specialty, whether it's an FMITE, or we actually, one of the things that we do help is to have them actually take an ITE, an internal medicine. And if they score very well, the program directors really like to see that. Because as you well know, Raj, when you're a program director, you're always looking at the ITEs of your residents. And the ones that aren't so high, you got to sit down with them and say, hey, I need that higher, right? So this is some of the stuff that we as Residence Medical over the years have tried to help IMGs who may have some score issues and they're not making the cutoffs for whatever reason. But again, these are all kind of, you might say, aggressive ways to show that you have, the potential to pass boards if they're thinking, I don't know this person or not. And it can be very effective. I've seen that over the year. Research, as Dr. Patel is talking about, too. Shivani, any other extra points you wanted to make?
Well, I have to say what I've been saying throughout this webinar, research, any opportunity to be in the hospital, just take it. And ITE prep, that's actually something great. I personally did that with Residence Medical. It not only boosted my chances, but when I'm a resident, which I will be in a few months, I would have to sit those tests. It's nice to be prepping for those from the very beginning. So that's really been very helpful for me. Sitting down with my tutor, getting ITE prep, actually having a taste of what my ITE in residency would look like. So those are something amazing that I've been doing with Residence
See,
Medical.
Raj, wouldn't that be nice? You got a resident, they come in, they say, hey, look, I'm already studying for my ITE. I want to do the best I can, and I know that's probably music to a PD's ears sometimes to say that, okay, I don't have to worry about this one, correct?
Yes, absolutely correct. PDs are always worried about low scores on ITE because now you have to create a whole education plan for that person, and you don't even know if they will execute the plan. So
that's exactly it. We have a division EDU that actually is growing across the United States with helping with ITE, with major GME programs too, and it is helping residents get better ITEs. The program directors seem to like it because one, the new generation is you can engage 24 hours on your cell phone to use this ITE prep, and the scores are going up. So the program directors really like that as well. But it also tracks the engagement. So, and you don't have to go and make the information. You've got enough problems as a program director getting all of that data. But it shows it'll read out for the PD to say, okay, how much they've been studying and what area they need to study better. My goodness, that's if you got that, that's half the battle right there. So then if they're going to do that, that study that you have to sit down and go through it with them. So that's right. That's really good. But Shivani, it sounds like you're being very responsible and a professional, and I think your program director is going to be really appreciative of your initiative and to do that. I think we're
Thank you so much, Professor.
Yeah, I think we're a little bit about out of time. Is that correct? Or we've got about I think 1 minute. I want to thank again Dr. Patel for your insights and sharing, and some really key points that I hope those who are listening will take away, just in terms of trying to be, focus on getting the job, and which you did, and look at those opportunities and not let them slide away. And Shivani, thank you so much for your sharing as well. I want to wish you wonderful 3 years in your specialty in internal medicine, and we'll probably hear about you trying to move into fellowship in a few years too. So,
Absolutely.
and hopefully, I'll wish you well to maybe become a chief there, so that when you're in the cafeteria, you'll be with the other chiefs there, as Dr. Patel said. Correct? Yes.
Good luck,
Yes.
Shivani. I hope you get the fellowship of your choice, because that's the key.
Thank you so much, Dr. Patel.
Absolutely. Thank you all for listening in. If you have any other questions, you need help, post-match, contact us. We have a lot of wonderful counselors that can really help you out in many different ways, as you've heard. So you guys all have a great rest of the week, and we will be in touch at the next webinar next month. Thank you.
Thank you, everyone.